Okay, Rima, when you want, you can open your video. You can start, Amina. Rima, when you want. Open your audio. Rima is closed.
Okay. Hello, everyone. This is the Congenital Heart Academy Fetal Webinar Series. We're back live again, and would like to welcome all attendees that we're lucky to have them today. And we have very eminent speakers from Brazil, very experienced in the field. And we're going to have 3 speakers, hopefully. We're waiting for the 3rd one so far. And this is our 13th episode. Hopefully, you're going to enjoy it. And please allow me to introduce our first speaker. And our first speaker is Dr. Gustavo Favreau. Dr. Favreau, could you please unmute yourself and come to the screen? And Dr. Favreau is the director of Pediatric and Fetal Echocardiography in Sao Paulo. And Gustavo, could you be kind enough to introduce yourself? I mean, you have a very long and interesting CV, and we're honored to have you.
Yeah. Thank you so much, Rima. Yes, I'm director of the Echocardiography, Pediatric and Fetal Lab at the Sabará Children's Hospital in São Paulo and Beneficência Portuguesa de São Paulo. I'm very grateful to be here with you.
Okay, thank you so much. We're going to start with your first talk, interesting and difficult cases in fetal echocardiography. Please, 25 minutes, and then we open the floor for discussion. Thank you. Amina, could you share the screen now, please?
I would like to thank the Congenital Heart Academy organizing committee for the invitation. I'm very grateful to be invited on board, and it's a great honor and privilege to participate at this meeting. Watch those great presentations and get connected with colleagues and friends, especially my dear old friends, Grace, Victor, and George. Let's kick off and talk about some challenging cases from our daily practice that I'm pretty sure everyone from this audience ran into interesting cases too, and difficult cases too. Our talk today is highlight some pitfalls and pearls. I have no disclosures. In our daily practice, when we perform fetal echocardiograms, we first focus on checking what is the normal anatomy and structures. Then we might run into some venous flow that we are not sure about it. Then we ask ourselves, is that a normal flow or pattern? In this case, we see a vein with posterior course and on the right side of trachea. On the long axis, we visualize its vertical course from the abdomen to the thorax, which is an azygote vein, very common in normal fetus. The azygote vein usually arises either from the lumbar azygote vein or from the posterior side of inferior vena cava, around the level of renal veins. It passes through the diaphragm, reaches the mediastinum, and finally drains into the superior vena cava. The azygote venous system has many anastomoses with inferior vena cava and vertebral venous plexuses. This makes it an important connection between the two vena cava, which allows alternate drainage routes in case of an inferior vena cava obstruction. It's always important to observe the brachiocephalic vein, the direction of its flows, and if it is not too close to the sternum. And it's happened in hypoplastic thymus and in the George syndrome. In this case of a fetus with normal height, no cardiac defect, we observe the brachiocephalic vein with right to left flow and the presence of a persistent and isolated left superior vena cava. The venous anomaly of a persistent left superior vena cava, PLSVC, affects 4.5% of the general population. PLSVC with absence right superior vena cava, also termed as isolated PLSVC, is an extremely rare venous anomaly. Almost half of the patients with isolated PLSVC have cardiac anomalies. Always important to give our special attention to the pulmonary veins. On scanning in multiple planes and turning on the color Doppler with adequate machine settings, scale, gain, depth, compression. In this case of tricuspid atresia with aortic hypoplasia, we observe the left pulmonary veins with ascending course and draining into the brachiocephalic vein. Partial drainage of pulmonary veins can be very challenging, and especially from prenatal diagnosis. Therefore, it's important not only to check the drainage of pulmonary veins in the left atrium, but also explore possible anomalous courses to exclude such defect. When we perform fetal echo, it's important the 2D analysis followed by the color analysis. In this case, we visualize retrograde flow in aortic stenosis, and there is no cardiac defect. The heart is normal. Jugular vein and carotid artery are shown here on color Doppler, and the diagnosis was presence of arteriovenous malformation, AVM. Restrictive ASDs in fetal life, especially in HLHS, hypoplastic left heart syndrome, leads to a poor prognosis and may indicate fetal intervention. In this case of HLHS with double outlet of right ventricle, DORV, we visualize on color Doppler veins with red and blue alternate flow, to and fro flow, suggesting restriction. Taketazu described in 2004 an index divided in 3 variations, A, B, and C. According to the relationship between the retrograde flow VTI and anterograde flow VTI, it's a very efficient ratio, and we use in practice a lot. We see in the first picture the type A and normal flow pattern. Then the type B with mild restriction, we see increased A wave reversal, and the ratio is greater than 0.17. And in the last image on the right, type C with to and fro flow pattern with absent early diastolic forward flow, and we should be careful to position the Doppler sample at the pulmonary vein level. If we mistakenly position the sample size in the left atrial appendage, simulate a type C of Taketazu, as you can see in the image below on the left. Accurate analysis of the PFO allows us to detect an ASDs that may not close after birth and may end having surgical approach. Large ASDs without membrane of sinus type can be identified by fetal echo and repeat the echo in the first week after birth. These ASDs cases were treated postnatally by surgery or hemodynamics. Here are two videos showing a sinus venous ASD from a 26-week-old fetus. In some cases, we have the opposite. Instead of large foramen valley, we might see a small and with the membrane down to the left atrium, restricting the flow to the left chambers. Note the small left atrium and the arched phosphovalis membrane clearly seen here in the left atrium. Also, small left chambers and a small aorta and retrograde flow on isthmus. In this case, there was reversal flow in aortic arch. After birth, the child was okay, and left chambers normalized. This was a recent case, 37 weeks pregnant with late referral and technically challenging window. If you assumed it was an anterior trunk, and I thought about it, we question about pulmonary atresia, right? The color Doppler assessment was poor and I was not able to identify the arterial duct and the pulmonary branches outlet properly. Postnatal echo then confirmed pulmonary atresia. They are two different diagnoses, sometimes very hard to define. I would like to highlight about the perimembranous VSDs, as they might be hard to be diagnosed, and many of them may need intervention postnatally. As you know, vascular resistance is different in the fetus. It's important for us imagers to observe the 2D images with the heart a little tilt by looking the tricuspid tissue protruding into the perimembranous region and look for any discontinuity and make sure it's below the aortic valve. Sometimes you can't be 100% sure, but you can minimize to overlook or don't see such defects. For muscular VSDs, it's also important to use the color Doppler for bidirectional flow. Some genetic syndromes have very typical heart defects, like in trisomy 18. Those cases, you can see dysplastic valves without dysfunction and a large atrioventricular canal VSD. In this another case, we observe redundant hypermobile mitral tissue, absence of mitral subvalvular apparatus, and a thin left ventricle wall thickness. Flow at color Doppler shows to and fro and on left ventricle without restriction. In this example, we also see aortic atresia. I would like to share this rare case, I think, at least, research in the literature and couldn't find anything similar, and I'm happy to hear from you as well. We thought that the main and first defects are due to the absence of papillary muscles. Complete absence of papillary muscles itself is a rare condition. Usually when a papillary muscle is absent, there are cord that arise from a single papillary muscle inserted into the leaflets. Carpenter and Associates reported a case of posterior lateral papillary muscle abscess with cord arising from the ventricular free wall. Likewise, other reports are similar. Another interesting case, a fetus with an important increase in CTR, cardiothorax ratio, very obvious flow in coronary arteries by color Doppler. Actually, it was a fetus with anemia and high output cardiac failure. Fetal anemia has been known for many years as a dangerous complication of pregnancy. Its most common causes are maternal alloimmunization and parvovirus B19 infection. Although vascular tumors, arteriovenous malformation, thalassemia, or genetic metabolic disorders. Doppler assessment of the peak velocity of systolic blood flow in the middle cerebral artery for the diagnosis of fetal anemia and intravascular intrauterine transfusion for its treatment are the current practice standards. It's not common to see TDA without the vessels in parallel. In these pictures, as you can see, the great arteries cross each other, making the diagnosis more challenging by ultrasound. Fourth chamber is normal, and during the scanning of the output, we see the PA posterior in blue by color Doppler and the aorta crossing over the PA in red. Two different cases of pulmonary atresia with ductal restriction without any known cause for this restriction. In one of them, flow velocities are increased in the ductus to 3.4 meters per second, and IP 1.4. Scanning short axis is important as well during fetal echo screening. Here, two cases of isolated bicuspid aortic valve. Here we confirm the diagnosis, but often we are not sure about the diagnosis, or often we face poor image quality. Getting close to the end. Sometimes we go across atypical heart association, unusual, like this case of tetralogy of Fallot, TOF, with double aortic arch. It's very important that we do not be excessively trapped in the probabilities and the incidence of the congenital heart defects. Champions prepare for the unknown and the unlikely. In this regard, we have a 25 weeks pregnant lady that underwent fetal echo due to pericard effusion. Despite the good gain adjustment, it was crystal clear for the echo lab team that the hyperechogenicity of the arteries walls wasn't normal, and also was confirmed the pericardial effusion. The team thought about these possibilities. What do you think is most likely? Inborn error of metabolism, image artifacts, congenital infection, genetic syndrome, or idiopathic calcification. The hyperechogenicity in the arteries remains at 35 weeks of pregnancy, and after birth, we identify calcified walls, and revising the literature, we found this unusual diagnosis: idiopathic infantile arterial calcification, an autosomic recessive disorder with about 200 cases reported. It causes intimal proliferation, leading to organ ischemia and to death in most cases. We treated the patient with biphosphate as shown in experimental studies, and nowadays, our patient is over 10 years old and doing well. Currently, those patients are treated with biphosphate since fetal life. The study of congenital heart disease is exciting and challenging at the same time. I think we continue to grow by practicing, and experiencing those cases daily. And it's also important to understand the limitation of the technique. I want to thank all my team of fellows and colleagues, especially my team at São Paulo, Sabará Hospital, and at Beneficência Portuguesa de São Paulo. Thank you for your attention, and I'm happy to answer any question you may have.
Thank you so much. Very interesting cases, and probably we will have a few questions. And I have two questions for you, Gustavo, if possible. You said this infantile arterial calcification. What was that case treated? Who was the 10 years old treated with biphosphonate?
Yeah, it was a case that we have 10 years ago, and we never heard about this disorder. And we search, review the literature, and we find experimental treatment, and we use in our patient, and the hyperexogenicity of the walls, the artery walls, disappear. It's a rare disorder, as you see, with extensive calcification of median and large arteries. And children die mostly by myocardial infarction in the first 6 months of life, 85%. And half of the fetus have drops, and a few cases present in childhood and adolescents with seizures or myocardial infarction. And by the way, a recent article to 2021 article in the Frontiers in Genetics journal attribute the mutation to the ENPP1 gene for this disorder, and also highlights the treatment with biphosphonates.
I had two cases, and one, the high drops, one died before delivery and the other one died immediately after delivery. And as you said, it's autosomal recessive, and you have to do gene sequencing for the mother and father, and as well as the baby. But I'm very interested because we didn't know that they take biphosphonate, but you say that it's 10 years old and he's doing well and he's getting this biphosphonate regularly?
Yes, and in the past 10 years, all articles are using biphosphonate since fetal life. We don't use since fetal life, but they still use since fetal life now.
Also, you can give biphosphonate for the fetus?
Yes.
For the mother?
For the mother.
Oh, okay. Anyone from our eminent panels have anything to say about this case? Vitor or George?
Hi, yes. So hi, Rima. Good morning, everyone. Yes, we also had a case recently, maybe 2 years ago. We tried, if I'm not mistaken, the CHOP group, I think they did some study with a fetal treatment, but we treated patients. We had the same outcome as Rima. One patient died, unfortunately, and the second one we actually respond well with the in utero treatment.
Oh, so when do you start? This is research, right? But when do you start, and how often do you give the biphosphonate?
I don't recollect which week where it was this patient, because it's been a while, maybe 2 years ago. But what I do remember, we checked the literature, and also we found I have to put things together, but I think the family actually contact CHOP, and we talked to each other and we exchanged experience. That's why we treated this patient. I don't follow this patient, so I don't know the long-term outcome.
I know it's the rarities.
Yeah.
George, do you have anything to say?
I'm learning with you guys. I have no case in all the history, but something that's very interesting with very rare case, that we never will know exactly if what we are doing is really making difference or not. This is something for everything that's very rare. So sometimes we feel free to test many kinds of things that we can do, but it's difficult to have answers, for example, for medicine-based evidence in these cases. This is a challenge for us that when we are dealing with very rare cases.
But we have Gustavo here. He's saying that their baby is 10 years old and he's getting the treatment. And I think that was you were the pioneers in giving this treatment, and now CHOP is trying to do this. I'm very happy to hear that. It's a rare disorder, and it comes from probably high consanguinity rate. And the last year I've seen two. Before I've never seen anything. And also, Gustavo, you've put also another beautiful case with the aortic atresia, and you said this is like a rarity that needs to be written. So what was in this case that's a rarity?
You talk about this one with the absence of papillary muscles.
Oh, I'm sorry, I got confused. Okay, so this is the absence of, not the aortic atresia one.
Yes, with the aortic atresia.
Oh, it was a combination, a combination of aortic atresia and absence papillary muscle.
Papillary muscle. We think about it now. I would be happy to hear from you. It wasn't. I try to bring out this case because it was very rare. I think one was referred to us as a possible left appendage aneurysm. As we see, there is a phosphovalis membrane and another hyperbolic tissue next to, not related with the phosphovalis membrane. And we thought might be a mitral tissue. And the left chamber is not things like appendage. It seems more to like a ventricle, despite very thin thickness wall. But we see an apex and some contractility. After birth, the diagnosis was confirmed by echo and MRI. And this child underwent an oral procedure with fenestrate left ventricle exclusion, like a Starnes procedure for Epstein anomaly. And because of RV failure, the child needs ECMO assistance and had a huge cerebral bleeding and brain death. And indeed, the literature we review, and we see some cases of absence of one papillary muscle. And maybe it's a case of total absence of papillary muscles. We thought about it.
I think I didn't see it. My image was a little bit fuzzy. I could not see well. But when you describe for me, remind me a little bit of an unguarded mitral orifice. Because did you see any just reminiscent of a mitral valve? Because if there is no real mitral valve,
could you show this again? Because I think it's interesting if you have it with you. And also, there's mitral regurgitation, right, in utero?
Yeah, so it can be unguarded mitral valve orifice. So it's pretty much underdeveloped, the entire mitral valve. And
that's a catastrophe.
I think the presentation.
The images,
okay.
The images now is much better for me. I can see well now the videos.
But yes, let's go to the.
This one.
Yeah, I mean, there is some.
Okay.
Yeah. It can be it can be even a spectrum of abstain. No, but you can get an absent mitral valve. Yeah.
We thought about Victor, but we see the insertion like a normal offsetting right here.
Yeah, but it looks like there is no delamination of the posterior leaflet, so it's completely attached to the wall.
That's the other one.
You see a through and flow.
Through and flow.
Yeah. Yeah,
So
so
the jet starts from down, right? The
yeah,
jet starts from the lower 1/3 of the LV.
yeah,
Here's one of the other ones. We have the atresia, retrograde flow on isthmus,
Yeah.
and true and flow.
yeah. I
And
have
what
two,
about the short axis there?
But I have here the case. I maybe take a time to look for it.
But it's just beautiful. And what you said that the child didn't do well because he had a bad LV and aortic atresia, and the RV was
yeah,
okay.
but you see, even a tricuspid valve also is dysplastic, is not normal.
Yes,
Yeah, I think he didn't do
RVR
well post Norwood because of the tricuspid valve. So you know, Norwood was
isn't a normal RV2 hypertrophic,
yeah,
and maybe but don't have tubercular portion.
yeah.
Gustavo, genetics was okay for this baby.
So excuse me.
Genetics was okay, Gustavo.
Yes, genetics okay, no finger.
Oh, okay. All right.
And just
so
the cardiac
we're-
defect. The other systems, there's no another defect, no association.
Thank you so much. I think we have to move, and we will
Thank you.
go. Thank you so much, Gustavo. I think beautiful cases, beautiful imaging, and I think now we go to our next speaker, and this is going to have a lot of. I think we will have a lot of. Oh, there's one question for you, Gustavo. It's from Natalia. Was this a functional aortic atresia or anatomic one?
So anatomic and aortic atresia, anatomic.
Yeah, it looks like. Thank you so much.
There's no.
I'd like to introduce our next speaker, and Dr. George Yusuf Afuni. And George, could you please introduce yourself? You have a long literature and a beautiful book.
Thank you very much, Hima. I'm a fetal and pediatric cardiologist now here in Brasilia, the capital of Brazil. I made my training in São Paulo. Since 2000 to 2005, I'm here in Brasilia, and I work most of my time with imaging and intensive care. Very happy to be here with you. I hope to have good discussion with all of you. Thank you.
Thank you so much.
I think you have to share the video.
Yeah, Amina is sharing.
Pre-recorded. Okay. Yeah. Hi, everybody. I'm George Afuni, a fetal and pediatric cardiologist here in Brasilia, Brazil. In the next minutes, I'll talk with you about this important issue in our area, that is the art of family counseling, especially in complex congenital heart disease. I'll start this talk, remember, for sharing with you the history of this young lady here. We'll come back to 2008, when she was 30 years and she got pregnant. And in the 22 week of gestation, she made a fetal echo. And that time, a severe tricuspid regurgitation was found, or for a dysplasia or an Epstein anomaly, with a huge right atrium, like an aneurysm, enlarged right ventricle with systolic dysfunction, and some signs of fetal heart failure. In that time, she went for a counseling with a fetal cardiologist, and let's remember some phrases that were told for her. These are one: we are really sorry, but your baby has a complex congenital heart defect. The risk of fetal or neonatal demise is almost 100%. There's no cardiac surgery at all for this situation. And if you were living in Europe or US, you could decide for termination of the pregnancy. Here in Brazil, our laws do not permit this, but I know that in other countries, it can happen. So how did this family react to this counseling? The family decision was something that many of us usually go through, especially when we have some difficult disease or something like this. We go to God or to religion. We need something to support us as human beings. And some phrases that she remembers is written here. For God, there is nothing impossible. I'll pray and wait for a miracle. Faith. This is one word that many of these pregnant women and many of humans usually we keep this word as our goal in these situations. So what had happened when she was 34 weeks of gestation, the signs of heart failure were increasing. So we decided to make the delivery by a C-section. It's a girl. She had a birth weight of 2.4 kilograms. The diagnosis of a tricuspid dysplasia and tricuspid regurgitation was confirmed, but the patient had at that time some kinds of persistent pulmonary hypertension. She stayed on prostaglandin for 4 days. The pulmonary pressure was going down, pulmonary antegrade flow was going up, and this patient went very well. Here you see a picture when she's 10 days, then 6 months, 4 years, and now 13 years. And this is the image of her heart condition now, 13 years later. With, yes, we have here some mild or moderate tricuspid regurgitation, but she's completely fine. This history shows us how this phrase is really actual. This was written by William Osler, more than almost 2010, well, 1 century ago, that medicine is a science of uncertainty and an art of probability. Everything we do in medicine, we can tell that we don't have all certainty with them. And everything works with a probability of happen or not happen, work or not work. This is one of the main points of the medicine, and we have to keep this in mind when we give a diagnosis or when we prescribe a treatment, and what are the expectations that the patient, parents, and us, and we as doctors, we want with this any kind of treatment or diagnosis. Well, let's come back here to the counseling. When we have here in Brazil, this is a workflow for pregnant women in the prenatal area and what they should do if they have a heart defect, a heart problem. Look here. When we have a pregnant woman, usually wait that they have 1 or 2 ultrasound as universal prenatal care. If we have a congenital heart defect suspected, or this mother have a high risk for congenital heart disease or an incomplete screening, these patients should go to a fetal echo, especially after 20 weeks of gestation. And here, if you don't have any congenital heart defect, you continue your habitual prenatal care. But if you have a congenital heart defect confirmed, we have here to divide in simple congenital heart defect or a congenital heart defect that will with no neonatal presentation, or a complex congenital defect with neonatal presentation. If you have a simple congenital heart defect, this pregnant woman is referred for a treatment, for the treatment of the congenital heart defect after delivery, and she can deliver in any kind of maternity. But if you have a complex congenital heart defect, you should go to specialized prenatal care with delivery support and perinatal care. Who does really need a family counseling? Any patient with a congenital heart defect confirmed will need a family counseling, either the simple defects or the complex defect. Because in this moment of the pregnancy, any kind of congenital heart defect or heart defect is something that brings a lot of trouble for the family, and they have to be really well counseled in this moment. For family counseling, one point is crucial here is time. Why time matters in this situation? For example, here we have a fetal diagnosis and 24 weeks. We should have the first fetal medicine or cardiology consultation done very close to this first suspicion. Maybe days, at most 1, 2, or 3 days, or 1 week, we should have this first consultation, because here time is very important. After that, many other consultations will be done until the baby is born here, when you have the neonatal congenital heart defect diagnosis, usually 39 weeks, and where here 7 days later, if everything goes right, we have the neonatal treatment. Look that this first time here between fetal diagnosis and the first appointment with a specialist for fetal heart defects or fetal medicine should be very short. But look here, the waiting process that a mother who is pregnant with a baby with congenital heart defects will wait until the baby is born. Usually, they will have maybe 10 to 15 weeks. We put here in nights, just to have in mind, 100 nights, that this time is too long for this family, because every day they have, and every night, many thoughts, many questions. They overburden this patient until you have the baby. So these 2 times here should be in our mind when we are dealing with counseling. The first one is to talk with these families very short after the first diagnosis. And the other one is to help them to go through this long waiting process until the baby is born and treated. A fetal congenital heart disease diagnosis is a traumatic event for parents. There's a loss of the ideal baby. This family will pass for a mourning period, like if she lost somebody from his family. It's almost the same feelings they have. They are overburdened of questions and thoughts. Many of them we cannot answer in this moment. Many of these parents, sometimes they feel guilty, and all of this can bring mother and father to a situation of anxiety and depression. So for this situation, psychological support may be crucial, and we have to try to support these families with this kind of support. After this diagnosis, one point that is very important for us when we make, for example, this diagnosis in a regular fetal echo is how we communicate this impression or this hypothesis for a patient during an echo, during a fetal echo. It's undoubtedly a bad news. So we have to develop abilities to how we communicate this bad news for the patients. There are many evidence that suggests that people overestimate the effects events will have on them, in that if that effect is stronger for negative event than for positive event. But here, this phrase from Robert Bias is how one delivers the bad news may play a key role in shaping how people initially interpret the information and shape their coping process from this point. So this phrase here make our how important is our first words when we talk with these patients, especially in the first echo. While sometimes we are making the echo, the patient is here, and we start telling them, "Oh no, it's a small. I find something here, but we are going to talk this a little later." So we have to take care of each word that we say in this area, because the first impression they may leave many marks in this patient for all their process that's going after that. So we have to train, we have to study about this, we have to be prepared to communicate bad news in this area. This is the 6-step approach that is used in many areas, not only in medicine. I review with you the 6 steps. They are very interesting, and how we can take these ideas for our work in the fetal family counseling. First of all, we have to assess the patient's understanding of that problem. For example, what do you know about this condition? Or what have the doctors told you? We should give a warning shot initially with some kind words like, "I'm sorry, I have bad news." We have to present the bad news using words or pictures the patient will understand. Communication is a bilateral act. Not only what I'm telling, but how the patient is understanding my words or my pictures. Usually, this 4-point here is very interesting. We have to listen to the patient. Sometimes it's better for us to be quiet and listen for the patient until this patient feel comfortable in this conversation. Additional information should be given in layers as requested by the family or patient, like peel the onion. So we don't have to give all the information, all the massive information we have about these problems in one appointment or in some 5 or 10 minutes. We have to go slowly through this all informations. The follow-up is essential in this, especially for complex congenital heart disease. This is just the beginning of a journey with the family and the baby. So we have to show them that's a long journey, and with this journey, we'll be together with them. Let's tell something about the specialist who's gonna take the family counseling with the patient. There are some essential skills that are very important for the specialists. The specialist should be a fetal or pediatric cardiologist or a fetal medicine specialist or both. They have to have significant experience in fetal hemodynamics and potential in utero progression of congenital heart defects. They have to have significant experience in postnatal treatment and experience in long-term follow-up and potential sequelae up to young adult age. We, as doctors and fetal and pediatric cardiologists, we used to discuss many anatomical problems, many treatment issues about the period in utero and neonatal care. But parents are more interested in long-term follow-up. How will my girl or my boy be when she's a teenager or young adult? This contrast should be in our mind, because many times we go to discuss the anatomical problems, but they are not into in that moment. So we have to understand this feeling of the parents and bring them with a mix of both. We have to discuss what's here important, what they are more interested many times what's going to happen in the future. How we translate so many complex congenital heart defects for the families? Is it easy for them to understand these problems like we usually study or not? So we can use words, but many times pictures, drawing by yourself, or maybe some pictures for internet, they are very useful for this goal. We try to translate. This is what we call translating process and knowledge transfer about all the anatomical and physiological problems of the cardiopathy. Here, for example, in a hypoplastic left heart or the pulmonary atresia with VSD, I usually use these forms here to discuss with the families, and I think they really got some knowledge in this area. But I repeat here, these anatomical problems maybe are not the main problem that they see in this moment. What about the complex congenital heart disease? So the counseling in this moment is much more complex. Why? We are dealing with high mortality and high morbidity disease. There are different treatment options. Staged surgical treatment, outcomes. For example, we have local outcomes and we have outcomes from many centers in the same country and maybe in other countries. We have a very difficult decision about where to deliver this baby. Many times, families should move from one city to other, maybe from one country to other country, and this is a very hard decision for the family, especially if they have other kids and the other kids are in school age, for example. And what about the long-term neurodevelopment issues? We know that many of these complex congenital heart disease, they may have serious neurodevelopment issues in the future. Will all this be worth it? For some complex congenital heart disease, many of, I see that if we have some discussion between, for example, pediatric cardiologists, maybe some of them will think that for some lesions, it won't be worth it, all that these families do. For others, it can be really worth it. But the point here is not what I, as a doctor, think about what to do. But here, the point is to show the families all the tools, all the ways that we have, all that we have here, and try to find the best way for the family. We have to take care with our bias when we are discussing these points here. We have to try to always make a very accurate fetal congenital heart defect. Sometimes in fetal, it's not easy. We may have many doubts that we are gonna only solve them after birth. This is an example of a 26-week gestation fetus with aortic stenosis, here. Aortic valve stenosis here, we have here a velocity through the aortic valve of 2.7 meters per second. But the diagnosis of congenital valve stenosis, aortic valve stenosis, the phenotype after birth can be each of one of these 5 pictures here. We can have one here that we see if it works like a hypoplastic left heart syndrome. This is another one that we have a very dilated left ventricle. Maybe sometimes the left ventricle is usually normal, but the same diagnosis, you can have many other phenotypes. We have to deal with them and with the what will happen after birth. And what about these examples here? Here we have very enlarged right ventricles with Epstein anomaly, with signs of heart failure. Well, if you come back to 1994, we usually have a 10% survival in that area for Epstein. But now we have something about 75%. These results, the surgical results, change how we counsel these families many years ago, and they can change maybe 10 years from now. And what about the fetal intervention? Nowadays we know that critical aortic stenosis with evolving hypoplastic left heart, pulmonary atresia, and restrictive foramen valley are some main indications for fetal intervention. They are based on case series in large fetal cardiology center with encouraging results, but no randomized trial, we have that. And we should not minimize the risk of intrauterine death and preterm delivery. But how many centers are really able or prepared to do a cardiac fetal intervention? Should we refer all of these patients to the centers, or should we wait for the good results that we can have after birth? In these two images here, we can see something that can happen with congenital heart disease. Here we have a atrioventricular septal defect, and here a tricuspid atresia. But we don't have only the fetal congenital heart disease. We have more problems. In here we have a trisomy 21, and here we have esophageal atresia. So the risk of genetic syndromes and abnormalities depends on type of congenital heart defect. It ranges from 1% in TGA to 65% atrioventricular septal defect, especially chromosomal disorders, microdeletion, single gene disorders. But we can have many extracardiac malformations, gastrointestinal, abdominal wall defects, or renal. So this makes our counseling will be much more challenging, because you have the congenital heart defect, but we have one big problem side by side with this, especially for genetic problems. So should we do a genetic test in all fetus with congenital heart defect? Should we do a genetic test in all fetus? Would you really like to have a baby with a genetic syndrome? What would be the world like if there were no one more with a genetic syndrome? These questions are just for us to reflect, to make some reflections about what does really mean when we look for a genetic diagnosis, and what this diagnosis will bring for us in the problem of counseling, especially in the congenital heart problem. So finally, I'll show you here one example of a very good conceptual framework of how we should make this family counseling in congenital heart defect. I encourage you to read this very beautiful paper of Kovacevic, that in this paper, he showed us this especially 5 areas that are very important for counseling congenital heart disease. The first one is how we have to keep in mind how we transfer the medical knowledge for the families, how we achieve the trust in the medical staff. And we have to have very big transparency regarding the treatment process. All this here, these first 3 points, should be counseled by pediatric cardiologists, heart surgeons, fetal medicine specialists. Then you have the family dealing with their coping resources to improve their coping process, and the perceived situation control of everything that is going to happen with the baby, which should be supported by psychologists and social workers. Some ethical issues and shared decision making are important. And I want to remember you some points here. The goal of an optimal counseling session or multiple session is that parents make an informed choice, which is best for them and their family. This includes some discussion of terminating of pregnancy according to the country's legislation or comfort care. The decision-making here is often affected by social, cultural, religious backgrounds. Do not make directive counseling. Do not impose personal bias into the discussion. My final considerations are like this. Counseling for congenital heart defect is multidimensional and requires significant expertise in fetal and pediatric cardiology. Communication skills are essential. Structured interdisciplinary fetal cardiac programs are extremely necessary for this, especially for complex congenital heart disease. So, my final words in this talk is, in this complex problem here, I think that we have to use our brain to plan everything about the congenital heart defects. But we have to use our heart to explain the patients and explain the parents about everything they're gonna see in the near future. And what we really want is some picture like that, that with the fetal counseling, with the fetal diagnosis, with a good neonatal treatment, these patients can have a real normal life. Thank you very much.
Thank you so much, George. So beautiful talk. Unfortunately, we had some issues with the reading the recorded.
Yes, I have to apologize the audience because maybe the transmission of the video wasn't good. So I apologize for that. But next time
maybe they're asking if we could give it to Sasha another version, and then we can upload it.
Yes,
to YouTube.
no. If I share with you my original video, maybe it will be better. But yeah, let's go on. I'm really apologize for all.
No problem. It happens.
Okay.
George, I have 2 questions, and I don't know if the audience will ask. Now, could you said a 6-step approach to counseling. Could you summarize it again, like in a scenario, mother comes with a fetus with a VSD, and we are not sure. There's
small
no
problems, for small defects, for example.
Yeah, and then we will make a different scenario with small defect, a VSD that it's not very serious. It's gonna might disappear, might not disappear, and you made a decision as a cardiologist to tell her that there is a hole in the heart.
For me,
how would you
small
counsel?
is. I will give you my personal opinion because
you put a scheme with a 6 steps approach.
Okay. If you want, do you want me to share them again with you?
Yeah, I mean, if we can put this scenario and apply this to the 6 scheme approach in counseling. A clinical scenario, a 22-weeker with no extracardiac anomalies, and then as a cardiologist, as a fetal you found a small VSD there.
Let me just show you here. If you may I show?
Sure.
Okay, can you see?
Yeah, that's beautiful now. Yes.
Okay, let's hear. These are the 6 points. So if we are talking about small lesions, for me, small lesions sometimes is much harder than complex lesions, because for complex lesions, we already know that's tragic. We will have problem. We have to fix the problems. What's the first? In my opinion, what's the first problem here in the small lesions? We, as a doctor, sometimes we are not really sure that it's really small or medium, or it can develop something. So many times we will not tell the patients the certainty of the small lesions, and we keep something in mind. How we communicate this for the patients in the first impression is crucial for the coping process of the patients. So here, let's start with the small VSD. We can start talking with the patient. We're gonna tell him that we have a small problem. What does he know from this problem until that point? But here, I don't think this slide, Rima, is applied to small lesions, because here we are communicating bad news.
Okay.
It's not so bad, but this here is important because for the patient, a small VSD can be a bad news. For me, not, but for him, it's bad. So we have to take really care in this point to explain the problem, but do not alarm the patients. We have many patients with small lesions. They are so alarmed as if they have a big problem. So in this point, we have to make a counseling with them, maybe not in the same time or while we are making the echo. Maybe we have to discuss them the problems, because when you say the patient he has a small VSD, immediately he'll go on the internet, he'll go on Dr. Google, he'll find many other problems, and this will make him very endowed with everything. So here, for small problems, I think the art of communication is you have to take much more care and discuss them and do not alarm the parents. This is my opinion in this point.
Exactly.
Here.
So exactly the point is from an experienced person like you that although it's a small to us and we know it might close or maybe it's not going to have problems, but for the parents this is a very big issue.
Yes,
and we cannot minimize.
I agree with you. We cannot minimize
we
them.
usually start with saying we have good news, the heart is okay. I mean, I think it depends on also the how you see the parents, how you see they will take the news, and what is their level of education, and if they have 10 children, if they have one child, if this is an IVF, if this is a recurrent abortion. So the history of the mother and the father or the couple is very important in how you break even the smallest news. We have to be very careful. Supposedly I had a case with IVF and it's a small VSD, but that was catastrophic to the parents because they were waiting for 10 years to get this baby. And then
Yes.
you tell them, so well, you would tell them that I'm not sure if you would agree. I would say this is good news that it's a small one. And since we are not able to see it clearly, it means it's not that difficult. And then we say the valves are not really involved. The chamber ties are not involved. And the baby will grow up and you have to come back. Asking the mother and the father to come back for follow-up. This is a trauma.
Yes. Yes, if you ask him to come back, they maybe, oh, why is coming? He's asking me if it's completely normal. What's coming here? But one point here is that the term when you use small defect, what the parents really want is a normal baby.
Yes,
we always want a normal baby. But this term, when we break this normal baby. Even if I'm telling him it's a small VSD, I'm breaking the idea of a normal baby. That's because many times I ask myself if when we really have very small defects, shouldn't we tell them they are completely normal?
Some would say so.
Sometimes,
but I think legally we cannot do that.
But if we go to the echo, we have to describe the small defects, but we do not alarm the parents, and because sometimes it can be much worse.
Let's hear what Victor in Canada and Gustavo in Sao Paulo. How would you counsel this mother with a, let's say, pregnancy? I had a case with IVF and small VSD. I mean, how would you, a 22-weeker, how would you counsel, not complex. This is not very serious, but it is serious in a way to the family because this is a precious baby.
Yeah, so I think I agree with everything that has been said, and Rima made a very important thing. I think first of all, you have the start point is get to know the couple. My every single counseling I start here, from simple lesions to complex lesions, my first approach to the family said, do you know why you're here? I start from that point. So I can tell you in the first moment what amount of anxiety, what amount of knowledge I will start the conversation. And in some situations, and I can tell you, you talk about the IVF, which is getting more and more common here. We get small lesions. I jumped the very end of the conversation, say, it's just a small thing, but I have to go through and explain everything because I always do the same way. I explain what is a normal heart. I talk about the fetal circulation, postnatal, etc., because we have to do everything. But time to time during the conversation, of course, I always leave the parents very free to stop me and I watch them during the counseling. It's very important. You watch how they are reacting during the conversation. You can have some like body language, and you can go from there. And the small lesion, we have to, as Rima mentioned, we have for legal, we always have to do full disclosure. And the follow-up here, our policy, we do recommend, of course, for small lesions, postnatal and echo, but we get track on that, and we always leave the door open, and we check with this family. We have two amazing nurses working with us, and they always check with this family, even if they deliver in the community hospital, so where it's not connect with us. So we have some feedback. Just going back to the counseling, I think one I mentioned about seeing the family, but there is a nice paper, it's kind of an old paper about the bad news. And there's so many things that you have to pay attention. You have to look, how is the patient, how you will get into the room, if the patient has a partner, someone with them. During COVID time, we have a restriction here in the hospital, but for like even before my clinic, I checked the referral. In any patient high risk, I was mandatory for me have more than one person with a pregnant, because I think that's one of the key thing. You start with just a vulnerable woman in the room with the bad news. So I don't think it's fair. So there's so many things, patient position, so many things that we have to really pay attention. And I will resume summary what George said, because it calls compassionate communication. That's the key thing. That's the way we have to transmit that message.
And Victor, many times when we are making the echo, the first echo of a critical congenital heart disease, I think our faces, and we change our face when we are taking the echo, the images.
Yeah.
In that point is for me, it's very, I heard from many families that exactly point is in their mind many years later. So we sometimes it's not the right time to discuss with them, because we are not prepared to discuss during the echo. So it's very important to prepare for to very close. You have to prepare for that.
You have a very two different moments. So you have to, when you're performing an echo and when you sit together in the round table and you come for a conversation, that's a completely different moment. But there is something that is very important, depends on your type of healthcare. One thing that for me always strike me, the time that they are in the dark. When is the time they're in the dark? When they come from the referral when they come to see a cardiologist. So those days, those weeks for them, it's even worse when we try to predict prospectively the outcome during these 105 days, or whatever you called about the abstain. I
This
think
time
the
should be very short.
Exactly.
Very short.
So that's one thing that we work very hard here with the referral system, trying to bring this patient, especially high-risk patients, as fast as we can for obvious reason, management, termination, etc. But one of the key thing is protect this family for this stress, because the maternal stress, I'm going to say my next talk, I'm going to talk about psychobiological, and psychobiological fetal means that this maternal stress really affect the fetal. And that's one thing that we have to work very hard and start doing your fetal counseling.
I agree totally.
I think it's very important. Allow me to comment on both of you. Now, in Congenital Heart Academy, we talk to the whole world. So we have different standards, and we have different standards of practice, and developed, more developed in health system. So the message is that don't talk while you're doing the fetal echo, because
exactly.
Try not to talk to
not
your,
the time. Exactly.
Not the time.
Exactly.
No, so if you have fellows, if you have nurses, if you have students, because this is not. I mean, of course, most of us don't allow junior staff to the fetal room. They have to be at least fellows to go in because of the stress. The parents. I had last week. The mother did not. She's a doctor, and she came with a queer TGA. She didn't have breakfast, so she almost fainted on the bed because she was so stressed and thinking, knowing. I mean, she's a doctor; she knows what a TGA is and all that. So no, we shouldn't really talk. And as since I was also trained in the sick kids and different parts of the world, there is a very beautiful counseling room that you take the parents to in America also and everywhere. This is very important, and to have this room in different parts of the world, because this is a serious issue. It's not just telling the mother this is a TGA. It's a mother that has to stay for 14, 15 weeks carrying a baby.
Exactly.
And then thinking of also, as Vitor said, what is the marital relationship going to be? This is very important. We always think that it's not just, I made a diagnosis. No, we just started actually. The story just started. I always tell them we're going to be friends, prenatal and postnatal, and this is the first visit or second visit. And this is the other key point I would like to add is that what Lindsay Allen taught us, that there's a progression in utero. It's not me or you, it's nature, it's God, whatever you think of. Things are changing with time. So if the message is that, if we, as George said, because I come from similar culture, I mean, we say your face might look red or blue or whatever. Especially I had also a case with the mother. She had a hypoplastic right ventricle in the first baby and 3 operations, and the second baby was a hypoplastic right as well. So I tried not to show her anything, but I understand as a doctor, I was horrified. I felt very sorry for the parents. They come from a country where they don't have the surgery for a single ventricle, so they have to send the baby abroad. First baby cost them $2 million to do the story and the follow-up and blah, blah, blah. So the message also, I think we get from Georgia and Vitor, is that we have to stop the echo, take them to the side and try and counsel.
That's it.
The other thing
this is medicine. This is medicine.
But there is two more things that I want to just add. First of all, bad news in complex situations, it's already shown, they take only 20% of that all information. And one thing that for me, it is very important at the end, when you offer the options of treatment, whatever you offer into the family, I always tell the families, I'm here. Whatever you decide, I'm here on your side, and I'll follow you in your decision. If they go termination, if you're going for active management, or if we're going to do further with any procedure or anything. So because that's why we have to do offers unbiased, without the sugar coat that I used to say. We should wear the sugar coat, right? You should take your sugar coat, but it's still giving a very compassionate communication.
Victor, in Canada, I mean, they will call you back with their decision, right? So, and you have an assistant and you have a social worker and you have a team.
Yes.
I'm not sure how is it in Brazil, in São Paulo, Gustavo? So you counsel them, they don't take a decision. Do you ask them to come back, or they will email you the results? Because also the question, the delivery, where is the baby going to be delivered with this counseling? Yeah. And supposedly this VSD, I mean, from what we know is that it could be normal. It doesn't have to be a tertiary cardiac center. But if it's complex, yes, of course. But we're talking about the borderline cases and the counseling. Also, will they take decision immediately, or they come back to you, or they will email you, or what is your step? What is your system of practice?
Oh, amazing talk about this hard topic, George and Victor. And I am very great about George bring us out the 6 steps approach. And one step that I think we have to highlight, and I do it in my practice, in my daily practice, is the 4th one. That is, be quiet sometimes. You have to listen. I love it, George. Be quiet. Sometimes we need to do that for the parents, and heard about the dark times that they have until they get to us, to the final diagnosis, the counseling. And after we start to explain what is a normal heart, and then what is the fetal's heart disorders that has, if they are getting the information, as Victor said, sometimes they get 20-30% of the information. In this sense, I think it's so important, as Rima said, you don't talk while you're doing the scanning, the exam, because you have to look in the parents' eyes. You have to be there for them all 100%. And after the exam, I look for my schedule. And sometimes I don't have, I think even a VSD or a small VSD, I have to talk with the parents with time. We need time to do that. And sometimes I ask to the parents to go take a coffee and come back in the after I finish my schedule. And I think it works a lot. And in all the hospitals in São Paulo, we have psychological and nurses that help. And I think we and I see my colleagues, we can humanize this extreme situation for the parents. And VSDs, we explain, and I think in the final we be quiet, get back the feedback, what the parents understand about the talk, and we talk that it's okay. It's a common heart defect, small ones, if a muscular. If perimembranous, I would expect to do an echo postnatally for be sure that it's not a small one, because sometimes postnatally we see another way. But I love the 4th step, be quiet. Sometimes we need and expect the reaction of the parents, and we get to know them. Victor talk about it. We get to know the parents.
I think that we made a very clear point about counseling, because it's very important. Also, what George said, that who is doing the counseling. So pediatric or fetal cardiologist plus the MFM is very important. It's not either or, it's both, because we share the patient and we're just a consultation. Yes. They have the upper hand. George, you want to unmute yourself?
Yes, one final comment. We live here in Brazil that we don't have the option of termination. So our decisions go through for complex lesions. Okay, where is the best place for you to have your baby treated? So for us, as we cannot discuss, or maybe in the legal terms, we cannot discuss this. So we go through this. But what's our big problem here in Brazil? It's a huge country. Here we have, for people with insurance and money, they can have the best treatment. But for patients in public, we still don't have an organized program from the health system to bring a mother and her baby from the north, for example, to the south to have the baby treated. This is something that we have here.
Life. That's part of normal life, is that you have, even in the US, it's a vast country.
Yes, this is some contact. That's because when we are counseling, we should maybe have this in mind when we are discussing the patients, because we can, with our impression, lead them to make some connection that we don't know it's the best for the family. Also, sometimes it's very hard for them.
When this is also a very important point, when do you legally allow termination? Not at all, because in the Islamic world, Sharia allows up to 19 weeks. So I don't know, in Canada, is it 22 now?
25 weeks, 25 weeks, but 25 weeks. But we are actually allowed to termination anytime, even late gestation.
I mean for payment for the insurance, that you're allowed, of course, but for the payment, I think it's 22 to 24. So legally, if you want to terminate, so that the insurance will pay for that. I think it's up to
we have a public health care here that covers everything. And after 25 weeks, we just need to go to the panel for a decision for complex case. But to 25 weeks, any case.
One question from the audience to George: what about right aortic arch? How would you counsel them?
Oh.
It's a tricky one.
Yes. First of all, is it really a right aortic or not? This is the first point. We can make, especially now that we have many people making fetal echo and making images. Sometimes the time to get this experience, we have many of these diagnoses. And if we really have an aortic arch,
so it's isolated aortic arch, counseling for isolated right aortic arch.
If we don't have any sign of a heart defect or something like vascular annulus, if we don't have anything else, we can take this patient very easily as a small problem and check it after birth. But listen, the relationship between right aortic arch and trisomy 21 that it's done nowadays, I think it's something that it's not, I don't agree with this, because we can have right aortic arch in maybe 0.5% of the patients, of people, okay, normal people. But when we have in Down syndrome, they have a high incidence of right aortic. But when we are taking a scan, I think if we see a right aortic arch, it's more this patient. I don't think we have to make the hypothesis of trisomy 21, because the numbers are much higher. We have much more people without Down syndrome than with
it's not an issue. I mean, if you think it's trisomy 21, you can either ask.
We have many other.
IMFM to
yes.
double check with the anomaly scan, or you can do just an NIPT.
NIPT, yeah.
So, and the other thing, I just want to say, you tell them postnatally, you have to check that or antenatal if you want, that there is no anomalous subclavian with the right arch. So
yes,
I think that's the only thing that. And sometimes it's a double arch and we're not sure, and you think it's just it's a right aortic arch. We have Marina as a panelist with us, and she has a very nice comment. Marina, can you unmute yourself and give us your question? And you have a comment as well, Marina?
Just a quick about the right arch. I think right arch definitely is a small lesion, but I think the rule out aneuploidy, so you have to rule out a genetic syndrome. So of course we will go with the good news, but we have to be sure that, again, that's why the good communication with MFM to tell that this patient does not have aneuploidy. So in IPT, if the patient came already with an IPT done, and you have already screening, so you know it's a low risk, that's fine. But it's a high risk, unfortunately, you have to disclose to the family.
I'm really not sure about this because the numbers, but I respect this, especially because, for example, here in Brazil, it's not easy to make an IPT for everybody. You have to pay for that, and we many times we see doctors increasing this risk and asking the family to pay for this exam. I'm not really sure if this information, in especially the isolated right arch, will really bring us more benefits than not, especially if the patient will pay for that. It's just one point to discuss in the counseling.
Marina is saying congrats to all of you. In my center, we have a multidisciplinary team after scanning. What is it? After scanning?
We explain the situation in a different and comfort room. Mm-hmm. Afterwards, the family schedule with the pediatric cardiologist from the hospital or with the surgeon and a group of nurses as well. We are integrated is in information and programmation. It can be a slide from the, it's excellent, perfect.
Okay, great. I think for the sake of time, we'll go to our last but not least speaker. And we have Victor, and he's going to take us to the future. Could you please introduce yourself?
Sure. Can you guys see my
yes.
Just screen. Can you see full presentation? How you guys see my slides?
Yes.
Very nice.
Oh, okay. Okay. So hi again. Thank you. Thank you, Rima, for this kind invitation. Thanks for the Congenital Academy, Gustavo and Grace. I don't have any conflict of interest. Maybe just a quick disclosure, just Rima just announced about how about the future. But when Gustavo called me about this and he kind of suggested a topic for my talk, and I told him I have to do a full disclosure. I think Rima knows the program here. She has been here. We don't do routine. We don't do any special technique. We don't do 3D in our routine. So basically what we do here is a very consistent and deep echo with a long counseling work with the MFMs. So that's why my full disclosure. So when I got this topic, different direction in fetal cardiology, it's just for us reflect where we are now in the fetal cardiology, where we came from, and how we should think about future. Okay, so it's not exactly about the technology. Actually, technology is not my main topic in this today. So I just mentioned about where we came from. So when you talk about direction, I think that's one of the key things. So we need to understand where we came from. And now, in this current year, if we talk about the 4 domains of pediatric cardiology, we have several layers, sub-layers. We have to understand well embryology. We have to understand the development heart, as George pointed out. Heart during the fetal is like is a target moving, right? You know the heart defects moving. We understand the normal circulation. We understand the heart defects and the childhood disease. And don't forget, we have to talk in depth to understand as a preventive cardiology if you are a pediatric cardiologist. When you translate all this and you try to bring to the fetal cardiologist, we just discussed for like probably 40 minutes or maybe an hour about counseling. And we see that once you diagnose a congenital heart disease made in fetal life, the expectant parents should have like a detailed discussion about the diagnosis, the future, the prognosis. We go through everything. Right, so we have this about management options. You George mentioned about the local laws, the cultural difference, and the social circumstance. So I like to use what Dr. Furon put in one of his lecture when he brings that the ideal curriculum of the fetal cardiologist. So that's maybe this direction that we should go and we should start actually moving on. Of course, strong pediatric cardiology background, fetal cardiology circulation, major problems in therapeutic approaches in obstetrics. But one thing that for me, it's very interesting. We have to be awareness of the major philosophical concepts. So when you approach the family, you approach the situation, you have to really make like a broad overview of understanding the society, the cultures, the religions, and everything that we have to think in this. So it's definitely, I think the fetal cardiology, we have much more, I would say, broad direction than the pediatric cardiology. But as I started to know where we are, we have to look where we came from. We have to talk about past. To understand the present, I think the best way, or even to path forward, you have to look at backwards in time. And I think the history of the pediatric cardiology is it's fantastic. I think we have from the pathology, we have and the physiology. We started early when we started cardiac bypass. There was a big game change when you start doing surgeries, infant surgeries. And back in the 70s, I'm a proud Brazilian, so I have to mention about the arterial switch. I'm an echocardiographer. I think echocardiography definitely was a turn page in the history. And the prostaglandin, right? We kept all these newborn with the critical lesions. So this is just some few steps. And our generation, we are living the area of development. We know about neurodevelopment, we have outcomes, we have the interventional cardiologist was amazing, growing. And right now, unfortunately, the COVID the last 2 years changed completely and shake the world, but brought good things like the Congenital Academy happened probably because of COVID. We talk about artificial intelligence, but very much focus how we teach and how we do things remotely. So we had good lessons from the COVID. But what about fetal? So fetal actually came right there between the transition to two different areas, right? Pre-infant and post when you start doing infant. That's why our fetal started actually in the late 60s, early 70s. In reality, if you look at the real history of the fetal cardiology started with a Professor Wang in China when he did his first report of the M mode in the fetal heart. So that's what the real pioneer of the echocardiography in China, using this technique, using the heart rate and 140 mothers. In America here, in North America, in Chicago, was Dr. Fred Winsberg. He brought the A mode and he did in 13 fetuses, including 11 newborns as well. And he brought the idea how the potential role of the perinatal echocardiography evaluating fetal and neonatal cardiac. But definitely that was a big turning point was the 80s, right? I think that's what this next decade, the 80s, I think we witnessed it definitely significant advance in fetal applications. And one of the, I think the largest study was by Dr. Kleiman, who published this study in 180 fetuses from 18 weeks to 41 weeks. And they found two heart defects, one pulmonary atresia, hypoplastic right ventricle, and one unbalanced AVSD, and they detected two tachyarrhythmias. I hope you guys can see my screen well, but this is, I took from the paper because I said I have to show this. It was my first time seeing an A mode of the AVSD, and I don't know if you can follow my arrow here, but if you look at the arrow through the A mode, that's the way they can tell you this patient has a common AV connection with this valve moving related with the outlet septum. So that's why they start doing correlation and showing the 2D images with a diagram, and of course the post-mortem correlation with the anatomy. But we have to mention Dave Sam. He's brilliant, and as Lisa Hornberg called him as an ultrasound. You know, unfortunately he passed away very recently, but his contribution for pediatric cardiology actually was gigantic. And but what's interesting about his very beginning of the paper doing cross-sectional imaging, 2D echoes in human fetuses, why his eyes, how he's looking for the heart. In his paper, he's talking about physiological change. So he was wondering about the change during gestation and the ventricular adaptation. So it's a different perspective, how he started already to look at the fetus heart. And Lindsay Allen, right? So she doesn't need introduction between us. I think her contribution was again gigantic, but again a little bit different perspectives. She was very much focused in anatomical, and she brought the idea about the echo views and the correlation with the morphology. So that was very much anatomical views. But the biggest wave was when the Doppler came. I think the innovation involved the application of the Doppler in fetal cardiac assessment to change very much how we see this fetuses in terms of hemodynamics, right? And if I talk about hemodynamics in fetal, I have to mention about James Huta. I think Dr. Huta contribution, understanding, and bringing all concepts, evaluation of the fetus was amazing. And with the collar, I think Dr. Silverman actually followed all this decades, but he definitely, his contribution when he had the collar Doppler. And again, Lisa with her brilliant mind, you know, everybody knows that she is mentoring. She was mentored by David Sen, and she brought all these concepts. So all this, I think this is amazing. I brought all these ideas, just highlight how we made history, right? So I could add like several important landmarks, several other people that contribution. But for me, my intention was just giving a sense where we have been. And one good thing about preparing talks, although some headaches for me was a little bit tricky when I got this topic, but revisiting papers or people, always interesting, especially people who really think outside the box and bringing new ideas or visions about topics. I know Dr. Gil Vernovsky, he doesn't need an introduction. I should not even need to put a label on this picture. He's an icon for us in cardiology. And a few years ago, I was preparing a talk about Hashkin, and I ended up reading one of his paper, was like an editorial for the Hashkin lecture. And he gave this very interesting perspective about how we should interpret the progress, the evolution in pediatric cardiology. And what he did in his editorial, he brought some concepts that from this book, which means the short history of progress, with a very small world. They read this paper and put things together. He got this book from Dr. Bill Williams, who was a former surgeon. He had 6 kids. He's still active here. He comes from the Heart Center. And actually, I contacted Bill Williams a few weeks ago because I started reading this book, and we're talking and chatting about this book. So it really closed the cycle about this. But what Gil brought on this paper, and he mentioned about this concept of progress. So this is called like a Victorian concept of progress, which was published in 1972 by I think Sidney Pollard, sorry. And this actually, he stated that in the Western culture, when you think about the patterns of change exists in history of mankind. So we know that, but he says that this is a irreversible change in just one direction only. We only go towards to improvement. So it's true that we have this in our field. Definitely, we can actually even apply this. This is very interesting when we transmit for us in congenital heart disease. For us, what we had in reality, we have more incremental change in original ideas. Usually, because of development of later complication, we try to fix and improve these new ideas. So, which always bring or result in subtle change of this new idea. So, and which is further actually modified. So, if you will look for us in experience in fetal cardiology, we do reproduce very much this. I think maybe we had compared with the pediatric cardiology because you have the surgical, which really changed up and down in this curve. I think we have a very, I would say, straighter actually path towards to the development, and I think that's a very interesting. And I think we came from an area that was possible making diagnose, right? So it was a possibility of making this diagnosis in fetal life to the area that we have now trying to predict outcome, and mainly we try to change outcomes. So if I could choose three main factors that really should mention during this process, definitely, I think there was an extraordinary improvement in imaging technology. But I always say to remember that brilliant minds behind of technology. That's a key point. And we had a very good pressure, I would say, and because we have from the game change, the neonatal surgical results, pressuring us, put the pressure on fetal cardiology really to get this baby ready for intervention or in a good shape for a neonate repair. So I think that was a good actually push towards to the improvement, and we have to hurry up this last 30 years. But all this, we have to remember, now we understand much better and much deeper fetal physiology, fetal cardiac physiology, thanks to everyone, Dr. Rudolph, David Sam, Lisa, and everyone that brings hard work for us to understand. So all this is very important. And talk about David Sam, I think he was just brilliant. This 30 years ago, he said that diagnosis of heart disease is important, but in terms of the science of fetal echocardiography and where this field is going, I don't think that's where the action is. The action is really in the finding, tuning the diagnosis for prognostic information. So this is 30 years ago. He was just brilliant when he brought this, how we should make this diagnosis and really create this fine tune and trying to predict and prognose information. So, but let's talk about present. Let's talk about where we are now. Right? So I'm here in Canada. Rima just mentioned about we have to think that this is a world platform, that we have different countries involved. So George and Gustavo is in Brazil, and Rima is South Arabia. So, but we have to talk about the present. So the present of the pediatric cardiology, we know there is a huge difference in terms of diagnosis and treatment capabilities in the congenital heart disease in the last 80 years. There is no question. I showed the history, I could show numbers and survival in most of the heart defects. But there is a very famous quote that I really like it. So we can manage only what we know well and what we can measure. So knowing the numbers and knowing well deeply makes a big difference. This is a monumental data, and this is a fantastic paper people who loves epidemiology, want to understand heart disease, should read this paper. This was published like a year or 2 years ago in the Lancet. This is a very actually this is going on study doing by this GBDS group, which is a global burden disease group. And this map actually is just a snapshot how the infant mortality by cardiac disease around the world. And you can tell, you can you see the countries like Brazil, US, even divided by states, by regions, which is also very understand. And globally, there was in 2017, 261,000 deaths globally. That's a 34% decline from 1990. So it's amazing, right? How we improved. And from those, among this, 180,000 infant deaths. So I'm getting close. I'm talking about infant death. Say, and this is the most important message for this paper. The social demographic index, the SDI, was a marker to divide the mortality trends. And that's one thing that we should always bring in mind. So I'm talking about timing, and we have to make this compare these two areas, 1990 and 2017. And this is just a heat map, which is scrutinized and show in the ranking order of death by 100,000 children younger than 1 year old in two different times, in 1990 and 2017. And if you look at those orange and blue, and you see that in countries with a lower social demographic index, there is no change in the 17 years. So no question, I think congenital heart disease is a global public health concern, and the top 8 cause of infant mortality, all type of SDI, no matter where you are, your social development index, congenital heart disease is one of those cause. And unfortunately, in a low SDI, there is no change in the 17 years. So, but some people actually giving them a voice. So we have to think about this. We have to look at this. And I really like this editorial, was done by Brista and John Atwood. He's actually a diplomat working here in US. And Brista, I think some people know her. She works for the nonprofit organization called Chart Heart Link. And she called this invisible child, the child with a heart disease, a global health problem. And this paper gives us a very clear, is very well contextualized discussion. And I like the way they put it like in form of bullets, directions, and mostly all implications of how we need to improve as a society, the global and local healthcare systems to take care of congenital heart disease. Actually, we have to bring the past to the present. So in this paper, they mention about even problems like old problems like rheumatic fever. We have to bring and see this issue worldwide. So we are talking about we call like invisible child. So what about the invisible? I would say not invisible, they're hiding, but not invisible. What about the fetuses with the congenital heart disease? How they impact, how we should think about the global healthcare. And this is a very nice, very technical paper. It's a very recent paper, was published last month. And I really enjoyed when I was reading this paper. It was a coincidence also made by Bistra, which is one of the author. And this paper, so if you look at this, one of the authors, Professor Kumar, the KK as they call here in US, he is one of the, actually he is the leader in this field in cardiology in India. And he has done so many things in India for pediatric cardiology. I recently listened 2 or 3 podcasts with him. He's a fantastic man. And despite of being just a single center data, it was done in the south of India, in the province of Kerala. And the interesting about the context of this, they start a fetal program 11 years ago in 2011. They create this fetal program. Basically, is this a regional network of prenatal diagnose, referral, doing counseling by a fetal cardiologist, and planned peripartum. So basically, it's a very streamlined program that the way they're doing just referral, counseling, and planned peripartum. So for 2 years, they they do prospectively 105 newborns, being 77 underwent surgery, 28 with catheter intervention. And they did a cost analysis, but it's a very deep analysis of this cost. It's a very well done paper. And they compare prenatal and postnatal. Not surprised, there is a significant lower cost for neonatal cardiac care following prenatal group and planned peripartum care. Okay, this is not very much new for a lot of us here. We can imagine that. We heard this before, right? So, but the interesting about this paper, they show that for the addition to the absolute cost, the health expense to income ratio were significantly lower in prenatal group. So prenatal group from the multivariate analysis was the only modifiable variable affecting cost in the neonates undergoing to surgical procedures. What I like this paper, I just heard that George say that we have countries with several different counts inside the country. And that's one of the good message about this, because when you get a shot, a deep shot, and analyze the context of the heart disease, the impact in terms of cost in a province that maybe has a different income, different resource, you can really measure, and this measure, it's real. That's the real measure. So for there, we can really start discussing what's the impact of cardiac morbidity and mortality. Right? But let's step backwards and see, I talk about social demographic index. And how should we start analyzing impact of the prenatal diagnosis? Again, I'm using a world map. In this talk today is more like a global mindset. We have to think about as a global. Again, the Congenital Academy is a global platform. And let's paint this map according to the World Bank. And you can see low income, low middle income, upper middle income, high income, and for some territories, there is no data according to the World Bank. So when you ask about where is the impact of mortality in children and fetus with congenital heart disease, if you check and you look for data, where this data came from? This data came from majority, I would say almost 100% for developed countries, where they have a high level of delivery facilities, they have a good neonatal care, they have a postnatal surgical treatment adequate. I know Rima mentioned about the US, the different discrepancy between areas of the US, but if you think of the overall perspective, no doubt they can offer everything, and they have no real, I would say, financially prohibitive treatment of this fetuses with a heart problem. We have long-term therapies because we talk about long-term, it's a long journey with heart disease, and we have a very good screening program everywhere in the world. In the world development, we have a postnatal diagnosis, even those missing diagnosed, we have this, and mainly we have options in most of the countries with a well-established program of termination and compassionate care, something that we should consider for this population. But what about what happened on those, I would say, purple countries, sorry. I think I correlated with the cyanotic patients. So I don't want to overwhelm everyone here with those things that we know. Right? We have a lack of antenatal ultrasound prenatal diagnosis. We have a basics problem. We have a rubella immunization coverage. You have a serious problem about the human resource in the early diagnosis and intervention and treatment in this population, right? So we have problem with the equipment for surgery, cardiac surgery, perfusion, bypass, and no question, I talk about the visibility, right? The invisible children. The invisible children mainly came from those countries because it's not even included in the global health agenda, right? Because they don't have even really completing health priorities in this area of the world. We don't have funding for congenital heart surgery, and we have dedicated and we have the basics, right? This population, they have not even the basic, this mother, the care, right? So if you think that the WHO recommend one obstetric ultrasound in pregnancy in 2019, more than 80% of the women in Kenya do not even match this criteria. And 60% of delivery in Kenya is home delivery. So what's the plan to change? So what we've done, I don't know if you guys know that, but the UHN actually has a very interesting, we call like a sustainable development goals. This was released in 2016. There are 17 goals. And if you look at the agenda, the number 3 agenda is the major healthcare intervention, including a very important sub-item. We have to reduce the preventable death of newborns and children under 5 years of age for the 2030 agenda. So the target population will be the younger kid. And of course, I just show you, if you think you need to address that problem, you have to address congenital heart disease, because congenital heart disease contribution, I already showed you by the recent numbers, it really impacts. And fetal cardiac screening prenatal diagnosis change that. We can provide detailed counseling and facilitating and planning peripartum cares. So with that, we actually will affect mortality. We are contributing for improvement and met this goal for the UN. So, but do we have data from this population? And this is an interesting paper. It's a very simple paper, but show that how we have that area. I mentioned we have a very serious gap in epidemiological and outcome data from this area. The global agenda does not address the needs for children with the heart disease. But they show that they have a regional initiatives. And if you look at for each initiatives in different countries with different partnership, definitely bring that. We do have new methods that we can teaching, we can training, and they demonstrate that it really improves outcome. And you can use the local capacity building for this purpose. So I think the interesting to look at this paper, because what they brought me and they highlight that how we should use innovative and partnership to provide high impact, I tell you, low cost and innovation solutions for this problem. And I just talk about the prenatal screening. I think we have to break away this concept about MFM or fetal cardiology, pediatric cardiology. We have to make this simple. We have to train obstetricians in those areas to really diagnose congenital heart disease. And from there, all these actions that we know this. We have to do pulse oximetry. We have to do medical health care distance, follow these newborns. The training opportunities is something that it's very, very important. I think you really make things simple. The point of care diagnose the echo guide conditions. I think all this, and one thing that I completely agree, we have to think about cath intervention or for this critical lesions in this period, right? We really can make things simple and try to bridge up, make a bridge for surgeries. And I mean, we definitely need to think about as a global care. We have to think about this mother caring, right? The mother, Rima mentioned about the mother carry a baby for 40 weeks of very severe heart lesion. We have to really think what we can offer for this population. Are they really offering anything? Compassionate care, options of management? We have to discuss discuss this and bringing this for this very, I would say, vulnerable population and vulnerable patients. And I start my talk showing about the development area and the COVID area we're living now. And I think that's definitely was the good, I would say, legacy. That's a very nice legacy we learn. We can teach, we can do telemedicine, we can train people, we can communicate with each other. I just mentioned about the Congenital Heart Academy. If you look at the vision and the mission of the Congenital Heart Academy, they've done that. We talk to each other and we actually spread knowledge and discussing all around the world. I think it was a very good legacy in helping for this very, very important and hard work, right? I think that this picture is a beautiful, beautiful picture of National Geographic about how the hard work, how the teamwork, and in very, I'd say, extreme way, you have to coordinate and do this very hard work. And I'm using this metaphor to talk about the journey of caring congenital heart disease. I think George mentioned about the long journey. There's no question. Now we start 13 weeks, so you can do a early fetal diagnose. And from there, all these obstacles, all these challenges start doing your diagnose, your counseling. I don't need to go through everything here, the genetic counseling, the diagnostic management with the newborn with a critical lesion. I think this time of the journey is very important because we really stress and test your healthcare, how we able as a healthcare system to take care of these critical lesions and follow these patients during the childhood. Unfortunately, there's late diagnosis, re-intervention, and bring this patient to grown up to adult world, and with this new more, I would say, problems about compliance, management, and re-interventions. Everybody here in this panel, in this audience, I think we know very well. I don't need to go through this long journey and repeat again step by step how we predict, how we follow these patients, etc. I think everybody here has a very good, solid pediatric cardiology. But we have to think, is this only direction that we're moving? As one of my tasks here was to talk about different direction in fetal cardiology. So we have to think and make this wider. So we have to think about neurodevelopment. We have to think about brain maturation, how the congenital heart disease actually affects. And this is a recent paper, I know it was published in a radiology paper, but Jane Newberg is one of the authors. They reviewed 69 fetuses with the perspective with 48 with congenital heart disease and 21 normal from 25 to 35 weeks. They did a fetal MRI and they did a score, a specific score to calculate this fetal maturation. And they found out the fetal maturation score was significantly lower in congenital heart disease. Of course, there's no way to differentiate for anatomy or physiology, but this is a very important message, right? So neurodevelopment outcome and clinical significance, we don't know yet. So this is new. That's definitely, we are looking at this in fetal practice every day. We talk about this with families. And just going back what Gilvernovsky said about new ideas, revisiting concepts, and this came from the neonatal outcome. Everybody knows about the Boston circulatory arrest trial. That one of the landmark paper showing that there is no question that there is a neurodevelopment vulnerability. And this trial was clear comparing the cardiac arrest versus low flow bypass. So definitely, we're revisiting this topic, bringing us to this fetal. Maybe we should start a new direction of evaluation of this fetuses, very much related with this brain maturation and neuro development. So when you talk about the brain maturation, neurodevelopment, we have to think about fetal development. And the fetal development, I think it's an interesting topic. It's being for forever, being decades that in the investigation, there's several papers, very cool, interesting papers in animal studies showing this concept of how the psychobiological effect of the fetal diagnose. So, and it should be part of the journey. I think that the mental, I just mentioned about the mental health expected parents, because the neurobehavioral and emotional outcomes can impact the child with a congenital heart disease. So it's something different that we have to think. And Jack Rajek, he showed very nicely a few years ago data showing that how those families, those mothers, post counseling with the bad news, they develop severe post-traumatic stress, depression, and anxiety is very common in patients with congenital heart disease. And his data show that healthy partner relationships and positive coping mechanisms can act as a buffers. So that's why I brought this about how we should approach and how the integration of the mental health services in fetal cardiology is something that we should start, even if you are in the base of the pyramid, if you're like the front line of this families, when you see this family for the first time, you have, this is universal. You have to really engage a very, I would say, compassionate communication. It's you have to have a really nice sense of this, at least the basic of psychological support or psychoeducation for this family. If you are not able, you can have someone to help you, a training nurse or even a social worker or somebody to help that. And from there, it can escalate for the top of the pyramid when you have patients that you really identify a severe stress on that family, and that should something that should be highlighted, and it's our job actually identify that, so that the impact of this psychobiological cycle should be identified in the fetal cardiology in the counseling. And psychobiological is not something that new, right? Everybody now I start talk about prevent cardiology, and the landmark paper for late development heart disease and in adult came from the landmark paper from the British group that when the David Barker published about the growth restriction and malnutrition actually was late development, and he brought this concept how we remodel these hearts and how we create heart disease from the prenatal circulation, right? Basically show the fetal circulation, the placenta function, and the heart function that really affect and create this that he called the fetal programming. And that we actually develop those phenotype of cardiac remodeling and affect the vascular and later on hypertension. So the fetal program is something that we know for this model. So last but not least, I just talk about the fetal program. I have to brought this. I think artificial intelligence is here, right? It's a red between us. It's everywhere, and we need. I need to talk and at least give you. I'm not an expert, of course, but I just brought some little bit of a core concepts. It was a little bit paradoxical because I just talked about emotions and now I just moved for some artificial intelligence. So emotional intelligence moving to artificial intelligence was a little bit paradoxical, the order I put in this talk. But it's artificial intelligence actually, it's a computer science, right? And very what the science does with the computer. Basically, you teach a computer to perform some tasks, right? And you have to have some specific goal in mind, and you should not give any rules or how to perform the task. So basically, this is the basic concept of how we do machine learning. But there are several ways to do this machine learning, how we teach this machine learning. And deep learning, the DL, is one of the form of doing this. And what they call, the language they use, they call neural networks, which sounds very silly to say is like a neuronium, like a neural, looks like something human, but in reality it's not at all. And from these neural networks, you arrange in several layers. It can be the number of layers really depends on the complexity of the task that you giving this computer. And in medicine, in healthcare, the neural networks, it is considered the current actually state of art for medical AI. And all development in healthcare and disease has been done using the neural networks. And there's many varieties of neural networks, and the development, you can call convolutional networks for face recognition for computer vision, for example, or recurrent networks for language or language recognition, language processing. So, but what about fetal cardiology, right? So how we bring this to fetal world? Of course, I think this is just started for us. But when you think as a fetal cardiologist, someone mentioned about the fetal accuracy diagnose is something that's very important. So we think about screening congenital heart disease. So should be one of this main tasks that we should expect from this artificial intelligence. But we can be ambitious. We can think about like this example here. I show this hypoplastic LV with this very hypoplastic retrograde flow and the transverse arch. But we can try to get prognose and even in a very ambitious way to get what's the optimal perinatal outcomes and predict outcome for this fetuses. This is a list that I got from this paper. It's some data already published, some papers already published with a different approach, different target or different goals for this. I would just highlight this paper, which is done by Anita Mungradi in Stanford. If you read the paper, it's interesting because they very much focus how we train to scanning abnormal to normal with the plans and views. So I have no question. I think this is one of direction that we potentially can go. I think we just started, but it's something that we may see this in the future talk about this. So if I want to finish my talk about the directions in fetal cardiology or different directions, in reality, it was too ambitious for me to talk about change directions. I think no question. I think the sky is our limit. My goal, I think, was more showing that we can make something wider. Right. I think fetal cardiology, there's no question. I think has been head in the right direction. I think this road has been paved by incredible people, bringing important improvement in technology of fetal echocardiogram and understanding physiology. Our primary destination is to promote the best quality of patients with congenital heart disease. But very seriously, we have to think this is a fully care of this patient. So we have to think about everything related with that, not just focus on the heart defect, but I mentioned about how will brain development, psychobiological. And as a society, I think we have to think globally. I use a quote that George knows very well. Is a rock band in Brazil, and they said that humanity is inhuman, but the sun arises for all. I think that's one thing that we should think globally. I think we should try to minimize this gap, and everything should be able to have some good quality care. I have no question. I think since the beginning of the M-mode, technology always has been great ally for us in patient care of heart disease. AI is already here. We need to make this useful, but silly to say that, but without ever replace our emotional intelligence. So I go back to the sentence that I used at the beginning. The path forward is to look backwards in time, but we always have to be mindful of global perspective to craft the future in fetal cardiology, in pediatric cardiology. Thank you very much.
Thank you so much. It's a very, very, very important talk, and it's not easy to grasp. I'm sure we need a simplification of all in order to understand everything you said, because every slide has a message. Let me try to simplify things as much as I got. A first question to you, Vitor. Now, you're trying to tell us that we have to look at the past in order to go for the future, which is life, which is nature. Now, what do you do? What did you do with the Barker theory? And you said the Barker is basically, to my understanding, is that the fetal physiology and the neonatal physiology will predict your disease when you're grown up. And his sample was, I think, growth restricted fetuses, and he showed that they are, and he showed a lot, but I think the one that's very famous is the blood pressure. So, yeah. And also coronary artery disease. Now, where do you stand from his theory?
I'm a little bit suspicious to talk about this because I'm very much interested in aortopathy in the long term, even look at the fetus. So that's one of the reasons I visit this papers and all his work, I would say, in a deep way. To predict. I mean, unfortunately, in fetal life, in terms of if you want to think about our aortic stiffness and everything, we don't have resource to tell you for sure that if fetal growth restriction have some aortic disease or any vascular disease to predict. But of course, we have something postnatal data. We have even early infant and showing that they have some vascular disease. They have an intima media thickening, etc. So it's there. So I think we know. I think this information for me, it's important because again, one of the key role for us as fetal cardiologists is we talk about MFM, but we interface very much with the neonatologist, right? The neonatologist is not a cardiologist, but he has to be aware that he's taking care of a newborn that needs follow-up in the long term for broad questions, right? So I of course, I could not go deep for obvious reasons. My topic was very generic, but the psychobiological concept, the maternal stress, it's fascinating.
Before we go into this, because that's important one, this is the Reichert paper, right? But yeah. I mean, what did you add to I mean, what do you plan to add with this artificial intelligence, with a programming, with whatever I mean, all those new directions? What did we in the field of fetal cardiology add to Barker's theory after how many years, 20 to 25 years or more than that in the 80s? What do you think we added to his theory so far? So that
we talk about preventive cardiology. I think preventive cardiology is something that should be part of our agenda. So once you see this patient prenatally, you have to talk to the pediatrician or who else is taking care of that child postnatally. That preventive cardiology probably going to be part of that child. So if that child anytime develops some hypertension, we know that the red flag was done in prenatal life. We know that it was IUGR. So that, of course, you have to be very careful with this message because if a patient with severe IUGR or other comorbidities, the family has a list of priorities that they have to follow postnatally, visiting neurodevelopment, everything. But in terms of preventive cardiology, is something that should be on the agenda of that family.
You're trying to propose all fetuses with problems should be followed till, as Barker's did, till the 30s or whatever, or till at the end of the life? Are we planning in the future to have, I mean, a clinic to have all the fetuses with problems to be followed till death?
No, I will not make that simple statement, but I think one clear message for me for those vulnerable fetuses would be having a preventive cardiology as a part of the long-term follow-up. I think this patient may need to see a cardiologist during his childhood, right? So it can be, you don't necessarily need to go for a deep investigation. You know, sometimes it's not easy to do vascular studies in this early age before 8, 9 years old. It's hard to see this, but of course, if the patient develop any hypertension, it's part of the hypertension patient. You have to study this patient, have a better assessment.
I think what I'm trying to say that we're going to go beyond Barker. So from what you're saying, what we're understanding, hypoplas are not IUGR or something like that. We have a lot of data or specimens to follow for the end of till this fetus dies. So the preventive cardiology is not going to go only for IUGRs. I think it would go for every high-risk fetus. And then
simple coarctation, right? Coarctation of aorta, hypertension, vascular disease. It can be just a simple coarctation long-term patient with a coarctation of aorta.
We know about that they develop hypertension because, and then circular Willis anomalies. Okay, where does the artificial intelligence come in our lives now? Because this is also what
I think for me, Rima, my main thing now when I think about, because it's very easy to put like a nice diagram as I put, like how I put things, and you put some equation and the fluxogram, quality of data, right? So we start from there. So once you have really good quality measurements and data, I think that will generate. So that's why when I talk about the neural network, that means that reliable data. So, and that's one of the key.
Neural is equivalent to artificial intelligence, neural network.
Yes, a neural network is the way that you start creating your layers on that algorithm, because every AI, basically you creating an algorithm, right? And so when you start that algorithm, we start from the basic, we start from the data. I just give you an example. We here, a few years ago, we tried to do a model, which is prenatal diagnosis of coarctation. So we did an artificial, we compare 4 of us on the fetal cardiology group. We get a random diagnose, and we had complete blind diagnose and put the orders and make a diagnose, like even outcomes. Where you're going to see this patient, when you're going to do prostaglandin or not, correct, you have to do for every single patient. So we collect this data, and we try to get a computer model, the outcome, and see. It's very much replication of the AI compared with our decision making. It was very, very interesting, and it's funny because I think the computer beat us.
Never.
Yeah. I of course I talk about I jumped from one topic to the other because I talk about how we should be compassionate about those fetal diagnose, and there is no question, right? I think the AI will be just probably. I think you'll be a resource that we can get more, I would say, robust data. And if you think about screening, I think definitely, I think we should be a little bit more practical, less ambitious, and really focus what really, I'll say, matters right now. If you talk about accuracy diagnosis and screening and refer this patient, if you have a good system that we get a good screening initially, will be a big step. I think for us, I would say, until the patient get to us. I think the screening will be a big difference if we get this.
We agree to that. There's nothing, but I'm trying to make to the audience this term nearer to practice. So am I going to go and sit on a chair and with artificial intelligence, I have a built-in computer system in the echo machine. I'll do a 4-chamber view in 2 minutes, and then I go back to my chair and I'll ask for analysis for everything, and the data will come on the system. Is this what artificial intelligence?
Yes, that's what I needed in the paper. Basically, they create for like 4,000. I don't know, the numbers are ridiculous because like
that's similar to when you do 4-chamber in a
4-chamber. They measure 4-chamber. They start actually from the cardiac thoracic ratio, and they from there they start to streamline and see what's the heart defect. They all look at the axis, they look at the chambers, etc., and they start to actually differentiate normal, abnormal, if it's going to which kind of a lesion. So basically, that's why the computer did.
And then you will sign the report at the end. Yes, George. Could you unmute yourself, please? Sorry.
Well, I think one point that artificial intelligence is very different from human beings. They don't have bias. They will not have any bias. We as doctors, many times, we make measures that we want to make. We put here, we change here, what we are thinking about the diagnosis, especially for imaging. For MRI, for example, there are many data that the reconstruction of LV volume and right V volume is more accurate when it's done by artificial intelligence than for humans. But there's not, the point here is not artificial intelligence versus human.
But let me just say one thing. No, I have something to say.
Okay.
I do understand and that machines can do more accurate work, especially in fetal, but you have to give them the right template to get the data out of it. So if you give them a bad 4-chamber view, they will never give you correct data. So still the human factor is very important here.
Yes,
that's what I was saying.
We have to add one with the other. We have to, the ideal equation here maybe is the best of the human with the best of the intelligence artificial.
Working together.
Yeah. But the artificial intelligence can add many things to our bias and can check some results. We can, I think it can really improve. But one point I want to raise out here, Victor and Rima and Gustavo, is what really a parent wants with his child with a congenital heart disease. Does he really want to have the congenital heart problem fixed in the neonatal period and has a normal life? What does a normal life mean?
But
it doesn't, just a point, it doesn't mean so many consultations, so many, I think we have to balance something that what's really changed the long-term outcomes and what is going this baby go. One point here we have to balance is between all data, all researches, and everything we are looking is that what's really important for the patient's life in that moment. I think we have to balance this in our daily practice to lower the level of anxiety and to increase the happiness of the family with their babies. Don't you think? What do you think about this point?
But I mean, definitely, this is one of the. I would say I have to keep adding points that your system that when you do counseling. One of the key point when you say long term is very vague, but yes, we go through I go through everything. I go to how the kid will go to school, what kind of he can learning problem that he will have, sports, physical activity, endurance, everything. We have to go and touch everything, right? So it's part of your long-term counseling. You always bring that. And if you during the conversation, when you get to know the family, and you go and you get to understand also what does how much they want for that, what expectation for that kid. So when you go through that, so it's part of the counseling. We have to talk about this.
Yes, I agree. I agree with you. But we are talking about some numbers, right? Some probabilities. We are not sure that that patient will have, for example, school problems. And my question, I question myself is, should I talk this here in the first year, or should I wait, look in the child, and when the child has some problem, we'll be ready to act? I have these 2 points here, Victor. Do you understand? Because we have some numbers that will show us.
Yeah, I mean, again,
we have patients with higher risk and other with lower risk. Okay, we cannot say congenital heart disease as all. Maybe either hypoplastic left heart, they are not the same. Okay, we can have some patients that are going better than others. So it's difficult to make just one point, right, in this area. This is something that always keep me in doubt in this.
Yeah,
I think we have to wrap up here. Victor, you want to make a quick comment, please?
No, I think I don't have much. I think we really talk. It was nice. Which we had the chance to talk between all talks. I have to brought about AI. And as I said, it was maybe I jumped too much, too further about directions. But as my main message about when you think about direction, and my main goal here was just really open us in terms of perspective, how we should think in this fetus with a diagnosis, right? We have to make this broad. You know, it's a family involved. It's not just a fetus. It's not just the heart defect. We have a family dynamic and everything involved. We have to insert this in the context of a healthcare system. You have to insert this in the real reality of, like you talk about hearts, hypoplastic left heart. We have to think about the context and outcomes in your local single ventricles, and from there you guys, and you came this wider, and we have to think. We have to still bringing old problems, right? You have a congenital heart block. We did not develop pacemaker yet. We did not develop things that we make really difference for this patient. So it's old problem. It's problem for 15 years, 20 years. We still have to debate and bring this for the future. So again, it's the same mechanism. If we go back and forth, bring things over the past and imagine the future. AI was just, I think, was just a make people think.
A comment, Victor, was so nice to hear from you about the backward time in fetal echo, and highlights that we need brilliant minds behind the all technologies, the machines, despite you are beat once by machine, as you told, and so creative thinking, and you really get out of the box. And in this concern of worldwide concept about the child with heart defects, we strongly talk for our colleagues, especially fetal medicine specialists, about the investment and the funds, grant money, and time for T21, for trisomy 21, that has incidence 8 times less than congenital heart disease. And I think as a group, a worldwide group, we have to really improve the congenital heart disease, infantile mortality. And it was so great. Thank you for your talk.
Thank you so much. I'd like to thank the whole group. And someone asked as a question, and I'd like to, just before we wrap up, for the adopted, the sperms and the eggs, how would you counsel if there is, this is for George, a difficult question. How would you counsel the parents for a heart disease? Would you, because you don't have any consanguinity here, so you don't know anything about the sperm or the egg or whatever. It's just a donor sperm or donor egg. Is there a difference in counseling, or you would be just you would counsel them as normal for any congenital heart disease?
I will counsel as for any other any other congenital heart disease.
Okay.
In the first step, I will say the regular consultation.
Okay, I'd like to thank you all. I just want to say, Lisa Hornberger, my mentor, ex-mentor, and co-author, she's going to talk in May with her in June, I think, or no, May. In May, she's going to give us a talk, and one of the 3 talks is going to be artificial intelligence from her group in Alberta. So we learned a lot today about AI, and Vitra, I'd like to thank you so much for your talk. I'd like to thank George for his beautiful counseling and very emotional and humanitarian touch in counseling. I'd like to thank Gustavo for very interesting and difficult cases. They're very difficult, by the way, and you made it sound very simple the way you showed the imaging. Thank you so much. I'd like to thank our audience, and everybody can watch this series on YouTube under Congenital Heart Academy Fetal 3, and we will meet you in a month's time. Thank you so much, and good night.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.